this individual is appropriate for our thoracic manual interventions. So we're going to start with flexion and extension. Okay, so I usually will have people like block out like this. If they don't feel comfortable or they don't have shoulder ranges of motion, right, then they can potentially go here or maybe a little bit higher up. But I like this because it really allows us to lock it in. So first thing I'm going to have Talia do is, I guess we'll flex forward first. Great, and then I'm just like almost like helping guiding her, adding overpressure. You could just have her do it by herself, but we're really trying to like expedite the process and just really know, is this like a mechanical dysfunction? And so I'm just going to expedite the process by adding my overpressure and being a little bit more aggressive. Okay, so I'm looking for good like a contour and segmental contributions throughout the spine, and then if I'm gonna like essentially add pressure, it's gonna be kind of like this, almost like I'm turning a wheel, if you will, right? So anything, and then I'm like assisting her out of it. Okay, same thing with extension, right? So I'm gonna come here, and then I'm gonna be adding like this counter motion like that. If you're really like working hard for this because they're like a bigger individual, there are other ways that you could do this where I could put her on the stool and then offer my extension with my leg or with the edge of the table. For her, I feel like I can get pretty good extension over pressure. The biggest mistake is that if you were to come around, you would see that I would like pull off out of the pure sagittal plane, which would be unintentional. Okay. In regards to rotation, so for this one, I will have you just kind of cross your arms, and then I'm going to have you rotate as far as you can towards me. Yep, great. And then I'm going to come in, I'm going to block, I'm going to wrap my hands around. You can also go, if I may, just kind of go right through here. And that gives me a really nice grip. And again, I'm not going to pull her off her stacked position. I'm just going to rotate within that. And I go anything. And by anything, I'm asking if I'm changing her baseline symptoms. And then I would do the same thing on the other rotation. It has been described for like side bending. I don't typically do that. I think for all intents and purposes right now, we'll stick with like the sagittal and the transverse plane, especially because the ribs themselves block that lateral flexion. The other thing that you see on here, the first two bullet points is your compression. So if you just sit up, yep, normal, right? So in neutral, I'm just gonna add axial compression. Does that change your symptoms at all? Take a deep breath in, deep breath out, and blow it all out. Great. And then if you want, you can also bias that into, like, say they're like, yeah, it hurts when I extend. All right, and then so you be like a little bit arched, and then same thing. So I'm blocking here, and then I'm just actually compressing through the spine. And then flexion, obviously, you'd have her bend forward, very similar to how you were a moment ago. Yep.
Do you want me to go into it?
Yeah, if you don't mind. Yep. So then she's tucked, and then I'm really up, and I'm really flexing and bowing the spine. If all that's still good, do I do this on every patient? No, but it can further tease out like the bone integrity. Closed fist compression. So Tyler, I just want to know what your sensitivity is, your spine sensitivity is to mechanical compression, and I'd just be doing my closed fist compression, which is typically done for like spinal, if you're suspicious of like a vertebral fracture. The other thing that you can do that's a little bit more sensitive, a little bit more provocative as well, is you take the reflex hammer and you're going right down the spinous processes. But usually you're not doing the entire spine, right? She comes in, she's like yeah, it hurts like here, right? It's like, okay, how does that feel compared to up here? And you're comparing them from one segment region to the next. And then accessory motions are, I classically do this in a prone position. So let us go forth. Okay, just principles in general. The way I encourage you to be consistent in everything that you do when it comes to your assessment. So, Maitland trained therapist Dennis Dempsey, who I have high regard for, will always get the patient into the same position. She's a little bit extended, and he's a stickler about setup. Okay. The one deviation that I would make with that, I may put a pillow under the hips if someone is sensitive to extension. Talia, I feel like you're borderline here. Are you okay?
Yeah, I'm comfortable.
Okay, great. All right, so then with my hand plate, so we know that the skin and the fascial tension can go up to about 3 inches. So if my target segment is here, then I'm going to start with my pisiforms are going to be just like that, and then I'm going to take up the fascial tension, and then I'd be having a pisiform that grip or contact on both hands that meet at that particular segment, and I'd be working myself down the spine, again adding in that additional tension with the skin and the fascia. That is quite critical, especially if we were going to be providing a mobilization or manipulation here, is that if you don't take that up and then you thrust through that, is that shearing slack and energy leak can cost you up to 70% of your force. So that is pretty critical. All right, so that would, I typically will go down like CPAs, and then what I will also do is kind of get off into almost like a UPA, and I'll use, the typical dummy thumb is fine. I just find that it can be, one, a little bit pokey, two, it can cost you your CMC joint of your thumbs if you're doing this year in and year out. So I'm going to find spinous process. I'm going to drop off into the trough where I feel her erector spinae, and then I'm going to be a little bit lateral to that, where I'll be right over the facet column and the articular pillars there. So for me, I'll usually be on the ipsilateral side, and then I'm just gently working down, looking for, again, the same 3 components that we looked at with the cervical is how much effort and energy do I need to input to the system to get the mobilization, how much amplitude is occurring, and how much does it spring back off. And it's going to be relative from one person to the next. So you're really comparing one segment to the next. Okay. And then the next would be looking at the costovertebral. Okay, so then you're going to come off. Again, I find that I want to be kind of almost at an angle here versus with my spinal mobilizations, I'm purely down. So here I come on. I do come from the contralateral side because it helps just the angulation of how the transverse process meets the rib. I feel like I can be more at that plane, and I'm just now outside of the articular pillar. What I am not on is the angle of the rib. You start pushing on that, and you start breaking ribs, depending on how much force you're putting through. And then with the ribs, I'm not only going segment by segment and getting those 3 pieces of information, the amount of energy it takes, the amplitude, and the propensity for it to spring back up, but I'm also looking for symptoms here. And I will often have them take deep breaths as I do it, so that I can get a sense of the excursion of the rib cage with the slight expansion and posterior and internal rotation that comes with the inhalation and exhalation. I've also, so at times, if I'm feeling okay, that's looking pretty good, is the restriction more in the actual ribs themselves, then I'll come with a broad hand placement, and I'll be working myself down the thorax. Again, what I found is that if there's restrictions here, there can also be rigidity that they hold within the thorax itself. So I'll start again midline, then I'll go down the UPAs, costovertebral, and then into the rib cage to look at the actual mobilization there. This also helps me to kind of pinpoint if there is a treatable somatic dysfunction or joint dysfunction, like where are we going to be when I flip her over. If I was to do like a supine technique, it gives me a rough estimate as to where I need to put my applicator, my short applicator. Yeah. Thoughts?
Here, like just like how you were going on this side, I could block here and then go.
Oh, nice.
So that way we don't get like, because they should go together, but you can kind of get a little more precision with that.
Yeah. Awesome. Great. Usually what I'm doing is I'm like, okay, is there a spring? Does that actually give? Or is there rigidity? And then I'll usually say, all right, Talia, go ahead and take a deep breath in. Good, and deep breath out. And I'm getting a feel of that like posterior lateral expansion. Yeah. But I'm going gentle because I am more lateral, and that rib, it's mechanically the weakest at that angle. Yep. Great. And then perhaps we do, you guys want to break up and try that? Do you guys feel